Hello, in this episode we'll discuss systemic sarcoidosis. Describe what we know about the pathophysiology of sarcoidosis. It's an immune-mediated disease with non-caseating granuloma formation in several body tissues as well as increased CD4 to CD8 ratio. Remember that this indicates a type 4 hypersensitivity reaction in which we have two types of cells being involved. The granulomatous type 4 hypersensitivity reaction is mediated mainly by CD4 plus T cells, and therefore no surprise, while CD4 to CD8 plus T cell ratio is increased. Also, if you're asked about the immunomodulators, anything that can stimulate the macrophage mediated granuloma formation, such as interferon gamma and interleukin 1 and T helper 1 mediated response, could be the underlying issue on this dysregulated cell-mediated immune response to an unknown antigen. Describe the epidemiology of sarcoidosis. It's more common either among the African American or white Northern Europeans. Most commonly, again, at third or fourth decade of life in these groups. What are the pulmonary manifestations? Slow onset dyspnea with possible crackles and auscultation. What are the skin findings? Papules and nodules, especially in the form of erythema nodosum, as well as violaceous plaques resembling the lupus rash. Do you remember what's the name of this lupus-like finding in sarcoidosis? It's called lupus pernio. True or false, mucosal and oral lesions and ulcers are also common mucocutaneous manifestations of sarcoidosis. That's false. They are not seen in sarcoidosis. What are the two important ophthalmologic eye symptoms or signs? One is Zika syndromes or dryness, the keratoconjunctivitis Zika, and the other is possibility of both anterior and posterior uveitis. What are the neuroendocrine findings possible in sarcoidosis? One important one is the possibility of bilateral cranial nerve 7 facial palsy. The others are central diabetes insipidus and hypogonadotropic hypogonadism. Describe the findings possible in myocardial sarcoidosis. The granulomas can cause arrhythmias, most commonly high-degree AV blocks, also cardiomyopathies. What is the progression of the cardiomyopathy? Initially, restrictive is more common, but in the later course of the disease, it could become dilated cardiomyopathy. What renal and electrolyte abnormalities are possible in sarcoidosis? Similar to any other granulomatous disease, we could have hypercalcemia. This can predispose the patient to nephrocalcinosis and renal stone. Also, independent from hypercalcemia, the patients could have interstitial nephritis. What are the other possible symptoms? Organomegaly, lymphadenopathy, abnormalities of the liver function test, glandular disease, and constitutional symptoms such as malaise. What is Lofgren syndrome? The constellation of hyalomympadenopathy, erythema nodosum, and arthritis is Lofgren, and it's considered a variant of sarcoidosis. What is Mikulicz syndrome? Even though initially it was considered a relative of sarcoidosis and also had some mixed findings similar to Sjogren's syndrome, it is now classified under the IgG4 related disorders, and its constellation of symptoms or formula is uveitis, involvement of lacrimal and salivary glands, and possible couple other findings such as autoimmune pancreatitis. Always remember the hallmark is presence of IgG4 positive plasma cell infiltration in the tissues involved by the Mikulicz syndrome. Regarding the diagnosis of sarcoidosis, true or false diagnosis is clinical. That's false. Biopsy is required for the diagnosis. Given the multi-system involvement and a broad list of differential diagnosis, we need the biopsy confirmation. Now, what is our approach to biopsy? The best test, which is biopsy, is ideally performed from the less invasive, more accessible lymph node or skin manifestations. However, if these are not available, the transbronchial biopsy through bronchoscopy is required. Now, that said, given the fact that it's an invasive test and I mentioned it's the best test, what is the step-up workup for the diagnosis of the sarcoidosis from the first test to biopsy? The first test usually is chest x-ray. What are the findings in chest x-ray? Well, everyone knows bilateral hilar adenopathy. However, remember, it's possible to just have reticular opacities. So the patient may not necessarily have hilar lymphadenopathy, but may have only these reticular opacities against in the upper lung fields, and that is strongly supportive of the diagnosis. Now, what's the next step after a suspicious chest x-ray? The next step is still not the biopsy, it is CT. Why CT is important? Even though the diagnosis is made through the pathologic assessment of the biopsy, the staging of the disease requires CT assessment of the exact pattern of pulmonary involvement. What are these stages? The first stage is hilar adenopathy alone. The second stage is hilar adenopathy plus that reticular opacities indicating interstitial involvement. The third stage is disappearance of hilar adenopathy and only interstitial parenchymal involvement. And stage 4, similar to the final stage of almost all interstitial lung diseases, is advanced fibrosis. Note that most of these changes are seen again in upper lung fields. The final step that's required still for the diagnosis is demonstration of non-caseating granuloma without any dimorphic fungus or TB in the biopsy specimen. Now, this is the diagnostic procedure. Now, there are a lot of supportive labs in the diagnosis of sarcoidosis. Can you give examples? One is what we mentioned already, hypercalcemia with possibility of hypercalciuria and nephrocalcinosis and kidney stone. Now, do you remember what's the mechanism of this? Any granulomatous disease is associated with parathyroid independent activation of macrophage 1 alpha hydroxylase. That's activation of vitamin D that results in increased levels of calcium. I also mentioned, similar to other granulomatous diseases, we have increased CD4 to CD8 plus T cells. What's the test of choice to demonstrate these? That's bronchoalveolar lavage. Now, what are the other tests that hint in favor of sarcoidosis? For example, you find that test in a 30-year-old African American woman. That's increased levels of angiotensin converting enzyme. Now, you know this is a restrictive lung disease, so you expect restrictive pattern PFD. But if I ask you what is the DLCO levels in sarcoidosis, remember it's one of the interstitial type restrictive lung diseases. Therefore, diffusion capacity of lung for carbon monoxide is decreased. It's low. And finally, what liver function test can hint in favor of sarcoidosis, especially elevation of alkaline phosphatase. What can you see in CBC? We could see lymphopenia. Describe the initial treatment for sarcoidosis. If the patient is asymptomatic, observation could be enough. However, if the patient has symptoms or one important lab findings, we use corticosteroids. What's that important lab finding? That's hypercalcemia. Alone, hypercalcemia is enough indication to begin corticosteroids. Now, initiation of corticosteroids requires one important lab confirmatory assessment to rule out what differential diagnosis, TB and dimorphic fungal infection as other causes of hilar adenopathy should be ruled out before initiation of corticosteroids logically. True or false, an alternative for the management of hypercalcemia could be use of bisphosphonates. Yes, this is false, even though we do use bisphosphonate for the management of... That's false. Even though we use bisphosphonate for the management of humoral hypercalcemia of the malignancy, corticosteroids alone suppressing the macrophage response would be enough for the management of granulomatous hypercalcemia. Now, you remember bisphosphonates are the management for osteoporosis. So how come they are used for treatment of hypercalcemia? Remember, that the mechanism of action for bisphosphonate is preventing bone resorption. That's why they help osteoporosis. But prevention of bone resorption also means lowering blood calcium levels. So that is what we can also use them for certain hypercalcemic conditions, but not in granulomatous conditions that we can manage with corticosteroids. Now, what is the treatment in steroid-resistant sarcoidosis? We use immunomodulators, immunosuppressants such as methotrexate, azathioprine, or TNF inhibitors. Finally, we have an important set of differential diagnoses to discuss for sarcoidosis in general and for one of its relatives, the Mikulicz syndrome, that I want to discuss here. So, what are the important differential diagnoses given the fact that we said sarcoidosis is the diagnosis of rule out? Well, the causes of hilar lymphadenopathy, such as dimorphic fungal infection, TB, syphilis, lymphoma, and top of your list is pneumoconiosis with hilar lymphadenopathy. Do you remember what pneumoconiosis are associated with hilar lymphadenopathy? First and foremost is berylliosis, and the other one is sarcoidosis. This is very important given the fact that these conditions, similar to sarcoidosis, not only have hilar lymphadenopathy, but also are associated with the restrictive or interstitial pattern pulmonary function test. Well, the diagnosis is simple because they demonstrate a specific pattern of environmental exposure. In the case of TB, acid-fast staining of the biopsy could help, and in the case of dimorphic fungi, an underlying immunocompromised state or exposure to the endemic regions for each one of the dimorphic fungi would be helpful. And I would like to finish this episode by an important differential diagnosis between Mikulicz syndrome, the uveal parotid involvement in sarcoidosis, and Zika syndrome of Sjogren disease. How do we differentiate these two conditions and why such differentiation is important? Well, both conditions could be associated with dryness syndromes, the Zika syndromes, and both conditions could be associated with salivary gland involvement and joint symptoms. So three of the very specific findings of Zika syndromes and Sjogren is present also in Mikulicz. So how do we differentiate them? First and foremost, remember that Sjogren disease has more common manifestation of joint pathology in the form of arthritis or arthralgia. Second most important thing is that Sjogren is importantly associated with certain antibodies, especially anti-Rho and anti-La, that's the Sjogren syndrome A and Sjogren syndrome B antibodies. And dry mouth is also more common in Sjogren syndrome, though we could have dry eye and also uveitis in Mikulicz. Now, regarding the glandular involvement, the Mikulicz would show what specific findings. The antibodies that I mentioned for Sjogren would be negative, but the biopsy of the salivary glands would show a very specific pattern. If you remember, I mentioned Mikulicz syndrome is now classified as one of the IgG4 related diseases. The biopsy of the tissue in IgG4 related diseases would show IgG4 positive plasma cell infiltrates in the tissue. This is the most important finding in biopsy. Also remember, Mikulicz could show more strong association with autoimmune pancreatitis and nephritis, or could just manifest as uveitis and Zika syndrome of a case of sarcoidosis. So, put it simple, you have a patient in the age group with lung, skin, eye, or even cardiac symptoms. You perform chest x-ray, then heart resolution CT, and stage the patient, and then you are required to perform biopsy that shows non-caseating granuloma without dimorphic fungi or any mycobacterial acid-fast positivity. Then you begin corticosteroids if you have ruled out those infectious etiologies, and for refractory cases you use immunomodulators, and this is sarcoidosis.